We're going on with our series. We were interrupted last week with a COVID update on vaccination by Donna. Great recap, and really appreciate that. We're going to talk about preeclampsia with and without severe features today. Next slide. And it's continuation of this discussion. We had acute treatment of severe hypertension first, chronic hypertension with pregnancy, and then chronic hypertension with superimposed preeclampsia. So those topics have been covered. If you want to look at those slides, you can go to our website and take a look. Preeclampsia, just a quick review. Everybody on this talk probably understands how we make the diagnosis, but it has changed a little bit in the past. New onset of hypertension after 20 weeks gestation, and that's the key, where chronic hypertension is elevated blood pressure before 20 weeks. The blood pressure cutoff that we use is equal to or greater than 140/90 on two separate occasions, and it's always listed as 4 hours apart. It doesn't have to be 4 hours apart. If you've done the blood pressures and the patient has persistence of the elevation over that limit, that's enough. You don't have to wait the 4 hours, but that's a time frame that's usually stated. Protein spill is a key to the triad, greater than 300 milligrams per 24 hours in 24-hour urine collection. Another way to measure that is doing a spot urine and a protein to creatinine ratio. And if it's 0.3 or greater, that meets the criteria. Critically, and for the most accurate P/C, it needs to be an in and out cath. But frankly, in most offices, when you're doing a P/C, an in and out cath is not done. And it decreases the sensitivity a bit not to do an in and out cath, but it still is very helpful to know. Now, the urine dipstick is probably the least accurate, but if you don't have the capability of doing the others, using a 2+ or greater protein on the dipstick is something that we do use. It's just not quite as sensitive. When you get up to 3 and 4+, it's a lot more accurate, that it's going to be more reflective of a true protein spill. Click ahead if you would. So I always like to throw this in. Now go back to that. The old definition also included edema as part of the true triad of preeclampsia. And I put it up here because I make sure that you know edema is not needed for the diagnosis, but I think severe edema can really be helpful to us as a precursor for the onset of preeclampsia. We have patients who have significant weight gain of over 4 pounds in a week. That's not normal. And that's something to pay attention to, not just to blow off as a normal complication or implication of pregnancy. Next slide. So gestational hypertension, I'm really not a fan of the term, but it's out there. It's what our organizations use. And it's basically the same definition of preeclampsia, except there's no protein spill, okay? So it gives the implication that it just doesn't sound as bad, or maybe it's not as bad as we think it is. Next slide. So I put this here just to make sure that everybody understands gestational hypertension can be just as bad as diagnosis of preeclampsia with a protein spill. Both are associated with an increased risk of maternal and perinatal morbidity and mortality. Gestational hypertensives develop protein spill in 50 to 70% of the cases, and it may not even be until after delivery, but many of these patients will eventually spill protein. Both gestational hypertension and preeclampsia without severe features have an increased risk of progression to generalized organ dysfunction. And particularly if you see the diagnosis of preeclampsia or gestational hypertension before 32 weeks of gestation, the progression is much more commonly seen and it occurs more quickly. The other thing that I think is very important is long-term cardiovascular risk and long-term of continued chronic hypertension is the same with gestational hypertension as it is with preeclampsia. So don't let the name fool you. It is still a big deal. Pay attention to gestational hypertension. So preeclampsia with severe features just ratchets it up a little bit. It is a higher blood pressure. A blood pressure systolic of greater than or equal to 160 and or the diastolic greater than or equal to 110. Now, if you read the literature, it talks about these blood pressures on 2 separate occasions, 4 hours apart. And I put the smiley face there because most of us who deal with real life obstetrics know that this is not realistic. If you have a patient with severe hypertension and she comes in and requires treatment for that severe hypertension, you're going to recheck that blood pressure in 10 to 15 minutes. If it's still 180 over 120, you're not going to wait 4 hours. You're going to treat that patient. And that patient still by definition has severe features of preeclampsia. So the 4 hours is semantics. The proteinuria is the same with just the diagnosis of preeclampsia. Or you can have new onset hypertension, severe or just mild hypertension, with any of the following to give you the diagnosis with severe features. Next slide. So it includes a low platelet count, less than 100,000, renal insufficiency, which you know in pregnancy the serum creatinine is lower than it is in non-pregnant patients. And so if it's over or equal to 1.1, that's considered abnormal for pregnancy. The other thing that you can use is if you have a baseline creatinine, if it has doubled from what their baseline is. Liver impairment as diagnosed by twice normal elevation in AST and ALT, or if they just have persistence of right upper quadrant pain with less elevated liver enzymes. Pulmonary edema is seen with the leaky blood vessels that you see that's associated with preeclampsia, the vasospasm. They get leaky vessels and pulmonary edema that's very difficult to treat. New onset and persistent headache that is not relieved by typical treatment with Tylenol or other medications that we use typically. And then the visual disturbances that are also persistent. We call scotomata the spots in their peripheral vision that doesn't go away. I always like to throw this in. Donna can appreciate this because it wasn't that long ago that fetal growth restriction and proteinuria greater than 5 grams were criteria for severe features, and it was removed in the last updates. I still think that both are important. I think that the protein is not something you need to follow once it's elevated, but it does raise my eyebrows when I see heavy protein spill. And fetal growth restriction is associated with the uteroplacental insufficiency that you see from preeclampsia. And I think that it does, even though it's not listed as a severe feature criteria, it adds a degree of concern for patients with preeclampsia when you see significant fetal growth restriction, particularly early in the pregnancy. HELLP syndrome is one of the most severe forms of preeclampsia. Fortunately, it doesn't happen as often as just the garden variety preeclampsia. We see it a lot here in Columbia, and I know others around the state see it very frequently as well, particularly the tertiary care centers. The HELLP stands for hemolysis, which is indicated by elevated LDH. You certainly can look at peripheral blood smears and you can see evidence of hemolysis as well. Elevated liver enzymes, AST and ALT, are generally over 2 times normal, and low platelet count, less than 100,000. 30% of patients with HELLP syndrome will develop the true HELLP syndrome postpartum. So this is a true type of preeclampsia that we see in patients that come back either while they're still in the hospital or they come back in with atypical complaints after they've been discharged after delivery. 15% of HELLP syndrome patients will have either no hypertension or very mild hypertension and no protein spill. So you can be very fooled, and many times people call it atypical HELLP syndrome, but the bottom line is it acts the same, whether they have hypertension or protein spill or not. So pay close attention. And then the key to know is that presenting symptoms for HELLP syndrome almost always epigastric pain or right upper quadrant pain. So if you get a patient, and I can't tell you how many times in my career that I have had patients blown off by the on-call doc that gets the call and, oh, you've just got heartburn, don't worry about it. And then they come in a week later and their platelet count's 15,000. Pay close attention to that. If they have atypical symptoms and you're concerned, have them come in to have their blood pressure checked and labs checked. Nausea and vomiting is also very, very common in this population. So what do we do with gestational hypertensives or preeclamptics without severe features? When do they need to be delivered, and where do you go from there? And the bottom line is this is a group of patients that requires very cautious following. They have a significant increased risk of complications with fetal growth restriction, oligo, abruptio, fetal heart rate abnormalities, increased risk of preterm labor and delivery. So you have to watch them carefully. And typically what we do is baseline labs when we make the diagnosis, and then serial labs, whether you do it once a week, twice a week, however you feel is best for the patient that you're taking care of. Have them in for blood pressure checks and antenatal testing twice a week. I can't reiterate how important that is. And again, do not dissociate gestational hypertension from preeclampsia. Treat it the same. And if you have this diagnosis, delivery at 37 weeks, if there's not any progression to severe features, is the appropriate mode of management. Because if you continue to watch, there have been many studies that show that delivery at 37 weeks is much safer given the concerns of progression to severe features than not delivering. The severe features, how do we manage those? If it's hypertension alone and it responds well to treatment, we can manage those patients with in-hospital observation with monitoring, watching labs, and plan for delivery at 34 weeks. Now, if the patient has other severe features like pulmonary edema, central nervous system involvement, liver impairment, renal issues, low platelets, or if they have hypertension that is not responsive or requiring escalating therapy for that hypertension, the key is to give steroids, give them magnesium sulfate for seizure prophylaxis, obviously treat their blood pressures as needed, and then move toward deliveries after trying to get the 48 hours for steroids. And there are many cases in these situations where you're not able to get the 48 hours, but it's certainly worth a try at getting at least the first dose of steroids on board for fetal lung. Gestational hypertension with any severe feature that we've talked about, move on with the slide, and that is the same thing as preeclampsia with severe features. So again, gestational hypertension, I think, very often will fool us, put us to sleep, make us think that it's a less significant disease. And it truly, truly is not. It's a very serious condition that needs to be dealt with. I didn't really get into eclampsia. We probably will touch on that a little bit later. I didn't really talk about treatment of the blood pressure. We've done that before, but I'm happy to answer any questions that anybody may have concerning what we've covered today. And Donna, be glad to have anything, any input that you might have over what we've covered today.